In this unit, we are going to look at the anatomy and physiology of the urinary system. There are three main functions of the urinary system. The first is excretion. This is the removal of organic waste products from the blood. Second is elimination. This is the discharge of the waste products into the environment. And thirdly, homeostatic regulation. This is regulating the blood plasma volume as well as the solute concentration of the blood. These functions are performed by, first, the kidneys. These are the organs that produce the urine. They perform the excretory and homeostatic functions that we just mentioned. Second component is the urinary tract itself. The job of the urinary tract is to carry the urine from the kidneys to the outside. This includes the ureters, which are a pair of tubes that leave the kidneys, the urinary bladder, which is a muscular sac for temporary storage of the urine, and the urethra, which is an exit tube from the bladder to the outside. Urination, also known as micturition, is the process of eliminating the urine. There are 5 homeostatic functions of the urinary system. One is to regulate blood volume and blood pressure. The urinary system does this by adjusting the volume of water that is lost in the urine. The urinary system also regulates plasma ion concentration. These include the ions sodium, potassium, chloride, and calcium. Thirdly, the urinary system helps to stabilize blood pH by controlling how many hydrogen ions will be lost in the urine. The urinary system also conserves valuable nutrients. And finally, the urinary system assists the liver in detoxifying poisons. We're going to start and spend most of our time looking at the kidneys. The kidneys are found on either side of the vertebral column, and they sit somewhere between the 12th thoracic and the 3rd lumbar vertebrae. The left kidney lies slightly superior to the right one. This is due to the positioning of the liver that shifts the one kidney a little bit lower. The superior surface of each kidney is topped with the suprarenal gland, also known as the adrenal gland. A typical adult kidney averages 10 centimeters in length, 5.5 centimeters wide, 3 centimeters thick, and weighs approximately 150 grams. Looking at the cross-sectional anatomy, first structure you should notice is this indentation known as a hilum. We have seen this in several organs up to this point. This is a medial indentation where all of the major tubes come and go from the kidney. This includes the renal artery and renal vein, as well as nerves and the ureter itself. The renal sinus is the cavity or the space that is created by the hilum. The renal cortex is this light pink area out here. This is the outer superficial region of the kidney tissue. And then the renal medulla is the inner portion, the darker pink area, so the deeper pink tissue area. Looking at the organization of the renal medulla in a little bit more detail, there are 2 main components of the medulla. The major component are the renal pyramids. These are triangular structures that are found in the medulla. And each of these triangles end in this point or this tip. This is known as the renal papilla. So you see one here at the end of each of these pyramids. Between the renal pyramids, you see an extension of the light pink renal cortex. This is known as the renal columns. They are bands of cortical tissue that extend down from the renal cortex and separate each of these renal pyramids. We mentioned the renal papilla. This is the duct at the base or the tip here of the renal pyramid. This is where the urine is discharged into the next structure, which is known as a minor calyx. The minor calyx is a cup-shaped drain attached to each tip of the renal pyramids. The minor calyx tube runs between a renal papilla and the next major structure, which is known as the major calyx. A major calyx is formed by the union of 4 or 5 minor calyces. So we can see here, here's a minor calyx, here's a major. Here we can see 3, 1, 2, 3 minor calyces all going into a major calyx. The major calyx then empties into the renal pelvis. This is a large funnel-shaped chamber that takes up most of the space of the renal sinus. The renal pelvis is connected to the ureter, and then it's the ureter that ends up draining the kidney. Looking microscopically, the kidney is made up of nephrons. The nephron is the functional unit of the kidney, and each kidney contains roughly 1,000,000 nephrons. These are the microscopic tubular structures that are found primarily in the cortex of each of the renal lobes. The nephron is where urine production begins, and it also is connected to the main blood supply that comes into the kidney. Looking at this blood supply, the kidneys receive anywhere from 20 to 25% of the total cardiac output. 1,200 milliliters of blood flows through the kidney every single minute, and this blood is delivered to the kidney here through the renal artery. We'll look at the basic structure of the nephron, and then we'll look at the function of each of these different parts. Right. First, the main component here of the nephron is the renal tubular. This is the long tubular passageway, and it begins, this structure here is known as the renal corpuscle. Everything beyond that is the renal tubule. Now, one thing I want to point out, this is not typically the way the nephron would be in the kidney. It is extended out here so that in this picture, so you can see all of the components. Normally, this portion here, which is known as the distal convoluted tubule, wraps around and is actually connected and makes a point of connection between these two blood vessels. But spreading it out this way makes it easier to see all of the different parts. This structure here at the beginning of the nephron is the renal corpuscle. This is the spherical structure that is made up of a glomerular capsule, or also known as the capsule itself, glomerular capsule or the Bowman's capsule, the cup-shaped chamber, which is the space here, and the capillary network, which are this red structure inside. This is known as the glomerulus. Looking at the glomerulus in more detail, the glomerulus is a knot of capillaries. It's all this looks like this knotted mess of capillaries. It begins at an afferent arteriole. Same designation we've used all along. Afferent, A for arriving. This is the vessel that brings the blood into the glomerulus. And it ends, this is then the glomerulus, and it ends at the efferent arteriole. E for exiting. This is how blood leaves the glomerulus. The glomerular capsule is also often referred to as the Bowman's capsule. The outer wall here of the capsule is made up of simple squamous epithelial tissue. And as we can see, it comes around and it is continuous with another type of epithelial tissue known as the visceral epithelium. This is this purple structure here. The visceral epithelium is this epithelial tissue that covers the glomerular capillaries. The two types of epithelial tissue are separated by what is known as the capsular space. So it separates the capsular epithelium, this outer bluish structure, from the visceral, which is the more purplish epithelium around the capillaries. This is a blow-up inside. Here is the capsular epithelium. The yellow is the capsular space. These, you can see the red blood cell that is inside one of the glomerular capillaries. This pink structure, pink with the pinkish purple, this is the visceral epithelium. So you can see that the visceral epithelium directly covers the glomerulus or the glomerular capillaries. It is made up of these large cells, and the cells themselves are called podocytes. Coming off the podocytes, you find all of these projections. These are known as pedicels. Well, the pedicels from one podocyte make connections with the pedicels from another, and they create what are known as filtration slits. You can see these little gaps between the pedicels. These filtration slits are what help determine what can leave the blood. Materials passing out of the blood here at the glomerulus must be small enough to make it through these narrow filtration slits. Looking at the glomerular capillaries themselves, these are an example of fenestrated capillaries. We talked about that before. Fenestrated means they have these large pores or fenestrations that will allow materials to leave. So this is how urine is produced. We're going to filter out the blood. So we're going to force all this material through these fenestrations and then through these filtration slits. This creates the process known as filtration. Filtration is the first step in urine formation, and it occurs only here in the renal corpuscle. The driving force for filtration is blood pressure. Blood pressure will force water and everything dissolved in that water out of these glomerular capillaries and ultimately into the capsular space. This process produces a material known as filtrate. Whatever collects here in this space is known as filtrate. Filtrate has a composition similar to blood plasma, with the exception of proteins and formed elements. They will be left behind in the blood. So anything that is forced out of the capillaries into this space is now potential urine, what could ultimately be eliminated from the body as urine. Filtration, as I said before, represents the very first step in urine formation. It is a passive process because it relies strictly on blood pressure. So what happens now, the filtrate will enter into this capsular space. What makes up this filtrate? This filtrate includes many metabolic waste products and excess ions. You will find glucose, free fatty acids, amino acids, and vitamins, and water, lots and lots of water. Many of these materials are still potentially useful to the body, and we can't afford to lose them. So we have to recapture them or take a lot of this material back. You think about it, glucose is something that should not be found in urine, but it is filtered here at the first step. Our body takes a majority of this back. So after this process, as this material begins to collect in the capsular space, the filtrate then begins to move on into the rest of the nephron, known as the renal tubular portion. And these are the segments. The first portion is known as the proximal convoluted tubule. This is where many nutrients, ions, and some water will be reabsorbed or taken back. Then it goes into the loop of Henle. This is the U-shaped portion of the nephron that can extend partially down into the medulla. It consists of a descending limb and an ascending limb, and each portion will contain a thick segment as well as a thin segment. And then finally it goes into the distal convoluted tubule. Here is where secretion, and I'll talk about what I mean by secretion in just a moment, but this is where various ions will be secreted, as well as sodium, calcium, and water will be reabsorbed. After all of this is complete, each nephron then empties into the collecting system. The collecting system is a series of tubes that will carry that final product, the urine, away from the nephron. It's known as the tubular fluid or potential urine, away from the nephron. This consists of collecting ducts and ultimately ends in a papillary duct that drains into the minor calyx. Each collecting duct that we see here will receive fluid from several nephrons all at the same time. You can see all of these coming in, connections into the collecting duct. Each collecting duct will carry this fluid down to a papillary duct. This is what exits each of the individual renal medullas. And remember that the papillary duct drains into the minor calyx. And just to rehash from the minor calyx, so here's our papillary duct into the minor calyx, then it goes into the major calyx, into the renal pelvis, and ultimately out through the ureter. Now, there are two types of nephrons, cortical nephrons and juxtamedullary nephrons. Each has a slightly different function. We'll start with the cortical nephrons because these are the majority of the nephrons in the kidney. They're located primarily in the cortex region of the kidney, hence their name, cortical nephrons. When you look at them compared to the other type, the juxtamedullary, the cortical nephrons have a relatively short loop of Henle. And then we also notice these capillaries surrounding it. The efferent arteriole, the one that leaves the glomerulus, comes around, branches, and becomes what is called the peritubular capillaries. These wrap themselves around all of the tubular portion of the nephron. Now, we were talking about how glucose has to be taken back and water has to be taken back. These materials have to get back into the blood. That's what these peritubular capillaries are. They will reabsorb all of these materials that are removed from that potential urine and put back into the blood. Cortical nephrons are noted for producing basic standard urine. The other type of nephron are the juxtamedullary nephrons. Only about 15% of the nephrons are in this form. Their loop of Henles are real long and can extend deep down into the medulla. They have the peritubular capillaries that we saw in the cortical nephrons, but the peritubular capillaries here give rise to a second set of capillaries called the vasa recta. The vasa recta are associated with the loop of Henle, and again, they serve the same function. They allow for this reabsorption, or the blood that materials are going to be reabsorbed into. The juxtamedullary nephrons, their function is to produce a more concentrated urine. All right, now we're going to look at renal physiology, how the urine is actually made. So the goal of urine production is to maintain homeostasis by regulating both the volume and the composition of blood. This includes the excretion of metabolic waste products such as urea, creatine, and uric acid, but at the same time, it must keep all useful compounds in the blood, such as water, ions, sugar, and amino acids. Roughly 90% of all water that is filtered at the glomerulus will be reabsorbed. Now, the basic process of urine formation involves 3 steps. Filtration. This is filtering the blood, removing water and everything in that water from the blood. But as we said, many of these materials are useful and we need to get them back. This is reabsorption, taking back out of this filtrate vital materials that the body needs to keep. And then the last step is secretion. This is like a last-ditch effort to secrete or put back into the filtrate unwanted materials that we don't need. Now, I like to use an analogy to kind of illustrate these 3 steps. And this is a nice time of year to use the analogy because everyone's minds are on spring cleaning. So let's say, for example, you are going to spring clean your closet. So the first step will be filtration. You go into your closet, you pull everything out of your closet, and you dump it on the floor. Right? That's essentially what the glomerulus is doing, filtering everything out of the blood and putting it into this space. Well, obviously, you can't live with an empty closet. You've got to put some things back. So you start going through that pile and say, I like this, and you put it back in the closet. Oh, I really like this, and so on. That's reabsorption. You're taking from that pile and putting it back into your closet. And then the last step, secretion. Kind of look over what you have in your closet now and just, I really haven't worn that in a while. I guess I could live without it. You take it out of the closet, put it back on the pile to be gotten rid of. That is secretion. Okay? Taking materials from the blood, putting it back into that filtrate, back into the potential material that will be eliminated. What is left on the floor, okay, you are getting rid of. What's left in the nephron after these three processes, the body gets rid of as urine. All right, so we're going to look at each one of these processes and how it happens in the nephron. First is filtration. This process is no different than what we saw happening in our capillary beds earlier. There is this competition between two forces, hydrostatic pressure and osmotic pressure. So filtration consists first of hydrostatic pressure. This is the force that's going to force water and anything dissolved in that water through the membrane pores or the fenestrations of the glomerular capillaries. Small solute molecules will pass through these pores as well. Larger solutes, such as proteins and other larger suspended materials, especially our blood cells, will be retained or kept in the blood. This membrane also has a special feature that will restrict the elimination or the filtration of all circulating proteins, so they stay in the blood. The competing pressure is osmotic pressure. This is what would try to pull these solutes back into the blood. All right, let's look at this picture first. Right? Here, the pink, reddish pink, that is inside the glomerular capillaries. That is our blood. We can see the pores, the fenestrations. Here's the pedicels coming off the podocytes, and you can see these filtration slits. So inside here, we have the hydrostatic pressure that is trying to force materials out. In the yellow, this is the capsular space. This is where that filtrate is going to end up. This is where the competing osmotic pressure would come from. Right? So filtration pressure, this is the pressure that's going to force water and everything dissolved in that water out of these glomerular capillaries, through the fenestrations, through those filtration slits, and into this capsular space. This represents the difference between the hydrostatic pressure in here and the osmotic pressure out here. And usually the driving force is a pressure of 10 millimeters of mercury. Hydrostatic pressure is greater than osmotic pressure by an amount of 10 millimeters of mercury. What creates this hydrostatic pressure is significantly higher here in the glomerulus than capillary pressure elsewhere in the systemic circuit. And this is due primarily to the arrangement of the vessels at the glomerulus. A little bit difficult to see here, but the diameter of the afferent arteriole is slightly larger than the diameter of the efferent. Okay? Also, the diameter of the vessels, the glomerular vessels themselves, are also greater than the efferent. What this does is it creates a force inside of these vessels. Think about it. You have a large opening allowing blood to come in, but then a small opening allowing that blood to leave. Blood is going to build up in here. Think about you have a huge door to allow people into a room. You shut that door, and there's this very small door that allows people to leave. Okay, let's say we keep the big door open, so people can keep coming into that room, but they can only exit through a small, tiny door. Over time, things are going to back up. And that's what happens here inside the glomerulus. This helps to increase and to maintain that pressure, that driving force to push this material out. Glomerular filtration rate refers to the amount of filtrate that is produced by the kidneys every single minute. This averages about 125 milliliters per minute. Now, if you do the math, throughout the course of the day, the glomeruli will generate roughly 180 liters of filtrate every day. Now, if nothing else was done, this is how much urine you would produce on a daily basis. Obviously, we don't. Something else happens to this material. So we're going to go through the process of reabsorption, taking materials back. So as this material continues through the nephron, 99% of it will be reabsorbed. So as a result, we only eliminate 1 to 2 liters of final product that we refer to as urine. How is filtration controlled? There are 2 different ways we can control this filtration rate or make tweaks in the filtration rate. We can do it through autoregulation, which involves changing the diameter of our vessels, either the afferent, the efferent, or the glomerular capillaries, or all of them. And also hormonal regulation through the renin-angiotensin system, as well as the natriuretic peptides. Let's look at autoregulation first. Let's say, for example, there is either a reduced blood flow going into the glomerulus, or something has happened that the glomerular blood pressure is lower than normal. This is going to affect the filtration rate, and so the blood pressure won't be high enough to generate the normal volume of urine that on a daily basis. So what can we do? Autoregulation. What can be done to increase the pressure in the glomerulus? Well, we could dilate the afferent arteriole, open up the afferent vessel. This will allow more blood to come into the glomerulus at any given time. We could also dilate the glomerular capillaries themselves so they hold more blood. And we can constrict the efferent arterioles. This will make it more difficult for that blood to leave the glomerulus. You can do any one or all 3 of these, and the net effect would be to raise that blood pressure and increase the filtration rate. Now, what about the opposite scenario? If there is an increase in renal blood pressure and we need to back off a little bit, lower this pressure. Well, when there's an increase in renal blood pressure, this is going to stretch more blood coming through. This is going to stretch out the walls of the afferent arterioles. This will cause the smooth muscles cells in the walls to contract against the stretch. This ends up constricting the afferent arteriole, making the diameter smaller. Hence, less blood then can flow into the glomerulus, and this will reduce the renal blood pressure and the filtration pressure. What about the renin-angiotensin system? When there is a decrease in the glomerular filtration rate, this will result or cause the release of renin. Renin will then stimulate the release of angiotensin. What angiotensin does is it will cause the constriction of the efferent arteriole of the nephron, making that smaller. That will increase the pressure in the glomerulus and increase the filtration rate. So it elevates glomerular pressure and elevates filtration rate. Natriuretic peptides work the opposite way. Remember, they are released by the heart in response to stretching of the heart walls whenever there is an increase in blood volume or an increase in blood pressure. When this happens, AMP will be released by the atria. The AMP will then trigger the dilation of the afferent arterioles and constrict the efferent. Right? This will increase the glomerular pressure, increase the filtration rate so that you lose more water in the urine, and this will reduce overall blood pressure in the body. Our last 2 parts of producing urine, reabsorption and secretion. Remember, reabsorption is when the body recovers useful materials from that filtrate. And secretion is when we eject extra waste products, toxins, or any other undesirable solute into the filtrate. Both of these processes occur in every segment of the nephron except the renal corpuscle. Corpuscle is only for filtration. The relative importance of each of these processes also change from segment to segment. So we're going to look at what happens in each of these segments. We'll start with the proximal convoluted tubule. Again, let's set up this picture. The yellow is the tubular fluid. This was the filtrate that is now going through the tubular portion of our nephron. The purplish pink, these are the cells that make up the wall of the proximal convoluted tubule. So these are the cells of the nephron. And here are the peritubular capillaries that we talked about, the capillaries that wrap around the nephron to reabsorb these various materials. Any arrow that is going from the yellow into the blood, this represents a material that is being reabsorbed, taken out of the fluid, put back into the blood. Any arrow that's going from the blood into the fluid, this represents secretion. All right, so what can happen in the proximal convoluted tubule? We are going to reabsorb organic materials. This is where glucose, amino acids, any of these types of materials are going to be reabsorbed and put back into the blood. We also actively reabsorb various ions. Actively, okay, ATP, here's that sodium-potassium pump. All right, so we're actively reabsorbing sodium, but look at this, we're secreting potassium. We're going to reabsorb water. That's not shown in this picture. We can passively reabsorb other ions. That's happening over here with bicarb ions. And then secretion. Hydrogen ions can be secreted here. Potassium ions are secreted in this portion. Then we enter into the loop of Henle. So the loop of Henle, also known as the nephron loop, reabsorbs about half of all the water that was filtered out and 2/3 of the sodium and chloride ions that are present in this tubular fluid. And it does this through a process known as countercurrent exchange. This process, countercurrent exchange, even people at graduate level renal physiology have a very difficult time understanding. I'm going to very briefly outline what this is and highlight for you what I want you to know. I do not want anybody trying to figure this out in excruciating details. We'll keep it very, very simple. What this countercurrent exchange is, it's an exchange that occurs between the two parallel segments of this loop of Henle, the thin descending portion of the loop and the thick ascending portion of the loop. So again, looking here, here's our thin descending portion of the loop that wraps around and becomes the thick ascending portion. The pinky purple, this is your tubular fluid, okay, our potential urine. Around it, this represents the tissue of the nephron, and then wrapped around this, you would have your peritubular capillaries that would pick up some of this material. Let's look at the thin descending limb first. The thin portion here is permeable to water, but not solutes. So what this means is water can leave, but any solutes are going to be trapped inside. So as this tubular fluid flows down this thin descending limb, osmosis is going to pull water out into what's called the peritubular fluid, okay, or the area around the nephron and ultimately into the blood capillaries. This is going to leave the solutes behind in the nephron. And look at what happens. The osmotic concentration of this tubular fluid increases as the material travels down. Now we're going to go around the bottom here and start going up the ascending limb. This is different. The ascending limb is impermeable to water and solutes, but what it does is it will pump sodium and chloride from the tubular fluid into the tissues of the medulla. The ascending limb, is what creates causes this osmotic pulling of the water out of the descending limb. This is what we mean by countercurrent. The opposite, as the material is leaving the nephron, it is creating a current, a driving force that pulls water out of the material that's entering the tube, just opposite or backwards, which you might expect. Okay, the ascending, or as material is leaving the loop of Henle, okay, it creates an osmotic gradient that pulls water out of the material that is entering the loop of Henle. So again, what you need to know is that the descending limb is where water gets pulled out. The ascending limb is where sodium and chloride get pulled out. And it's the ascending limb, the ascending limb that is responsible for the water being pulled out of the descending limb. Whole gist of this, as I said in the beginning, half of all of the water in the filtrate will be reabsorbed through this process, and 2/3 of all of the sodium and chloride ions. Now we go into the distal convoluted tubule. The tubular fluid, as it arrives, it has an osmotic concentration that is about 1/3 of the material in the renal cortex. So there's a concentration difference. It's very dilute, not a lot of solute concentrations in what is left over. In the distal convoluted tubule, this is an area where potassium and hydrogen ions are going to be secreted into the tube. And we can see this here in this picture. Potassium ions, okay? The tubular cells are going to exchange sodium and potassium through these tubular fluids. This is how the body gets rid of excess potassium. We'll secrete the potassium and exchange it for the sodium. Again, our sodium-potassium exchange pump, and this is also under the control of the hormone aldosterone, which we'll talk about in just a moment. Hydrogen ions are also secreted here. As more and more hydrogen ions are secreted, dumped into the tubular fluid, this will acidify and the pH of our urine will decrease. As more are secreted, this will elevate the pH of the blood and the blood will become more basic. This process of hydrogen ion secretion accelerates whenever our blood pH falls. In other words, when our blood becomes more acidic than it should be. And lastly, we head into the collecting ducts. Reabsorption and secretion will continue to occur along the collecting system. First are these collecting ducts. They receive the tubular fluid from several nephrons and then again carry it down toward the renal sinus. What can be reabsorbed here? Sodium ions can be reabsorbed, bicarbonate ions can be reabsorbed, as can urea. This area of the nephron is under the control of two hormones, aldosterone and ADH. Aldosterone will control the sodium pumps in this area, and ADH will control the permeability of water. So we've already talked about aldosterone. Let's look at ADH and how this works here in this portion of the nephron. What ADH does is it will cause special water channels to appear in the cell membrane of the collecting ducts. This will increase the rate of osmotic water movement. The higher the levels of ADH are, the more channels will be inserted into this portion of the nephron. And it will have an effect. It will increase the water permeability of the distal convoluted tubule and the collecting system. So let's look at these two pictures. The second one here, this is when there is a high concentration of ADH, high levels of ADH. And in the presence of ADH, you will have these water channels inserted into the membrane. These water channels allow water to be reabsorbed back into the blood. The more water that is reabsorbed, as a result, you will produce a very small volume of highly concentrated urine. When there is no ADH present, there are no channels in the membrane. So water cannot be reabsorbed. As a result, you will produce a large volume of very dilute urine. The hypothalamus continuously secretes low levels of ADH. As a result, the distal convoluted tubule and the collecting system will always be permeable to water. At normal levels of ADH, the collecting system can reabsorb almost 17 liters of water a day, which is roughly 9% of the total filtrate. These numbers will change. If ADH levels increase, okay, you will reabsorb more water. If ADH levels decrease, you will eliminate more water. Now, after all of these processes are finished, we have our final product, urine. What is the composition of normal urine? Well, one, it should be clear and it should be sterile. Any bacteria that are present usually come or are present, get put into the urine as the urine is expelled from the body. The yellow color of urine is generated in the kidney from urobilinogens. These are the breakdown products from hemoglobin. The final urine is the result of filtration, absorption, and the secretion activities of the nephron that we have just talked about. Some compounds, such as urea, will be neither excreted nor reabsorbed. Organic nutrients will be completely reabsorbed and should not be present in the final product. All right, let's kind of summarize what we have just done, the whole process of renal function. Everything begins with the glomerulus. This is where the filtrate is produced, and the filtrate is produced by the renal corpuscle. Remember that the filtrate has the same composition of blood plasma minus the plasma proteins. Then it moves into the proximal convoluted tubule. This is where you see the active removal of ions and organic substrates. Then it goes from the proximal convoluted tubule into the descending limb of the loop of Henle. This is where water is going to be removed and go into the peritubular fluids, leaving behind this highly concentrated tubular fluid. Reduction in volume here occurs through this obligatory water reabsorption. Then we come around and enter into the thick ascending limb. Here, the tubular cells actively transport sodium and chloride out of the tubule and into the surrounding area. Now, the main solute left behind is urea. This accounts for a higher proportion of the total osmotic concentration of the fluid. Then we go into the distal convoluted tubule and the collecting ducts. This is where final adjustments in the composition of the tubular fluid are going to be made. Final adjustments over here in volume and osmotic concentration also occur in this area. And exposure to ADH will determine the final urine concentration. All right, so now we've made the urine. Now we need to transport that urine out to the environment. And this is the role of the rest of the urinary system. The next structure are the ureters. They are a pair of muscular tubes that extend from the kidney down to the urinary bladder. They begin at the renal pelvis, and they come down and they penetrate the posterior wall of the urinary bladder near the bottom. The urethral openings into the bladder are slit-like rather than rounded, and they are covered with a flap of tissue. This shape, this slit-like shape, helps to prevent backflow of urine when the urinary bladder contracts, and we'll look at how this is put together in just a moment. Looking at the histology of the ureters, they have an inner mucosa layer that is made up of transitional epithelial tissue and lamina propria. Transitional epithelial tissue, this means it can change how many layers are present. So again, depending on the amount of urine that is passing through, it can accommodate. The middle layer is a muscular layer. It consists of longitudinal and circular bands of smooth muscle. This is the same as what we saw along the digestive tract. This means that urine moves through the ureters via peristalsis. big misconception people have is they think that urine just kind of trickles or flows from the kidneys down. No, it is moved via peristalsis, so it enters the bladder with a little bit of pressure behind it. And then the outer layer is a connective tissue layer that is continuous with the fibrous renal capsule and the peritoneum. Urine then goes into the bladder. This is a hollow muscular organ that serves as a temporary reservoir for urine storage. A full bladder can hold on to roughly 1 liter of urine. When you look inside, the inner layer, the mucosa, has numerous folds or rugae, very similar to what we saw in the stomach. And just like the stomach, these rugae disappear as the bladder fills. In the bottom of the bladder, you see the trigone area. Tri for 3. This is 3 openings into the bladder. Right? So in the shape of a triangle. You have the upper 2 openings are where the ureters come in, and the bottom one is where the urethra exits the bladder. All right, so we talked about the ureters. We can see them coming down here, and they enter into the bladder near the bottom. Now, back in the digestive system, I talked about how the body is a unique feat of construction, but there are a couple of minor design flaws, and we talked about one in the digestive system. Here is another one in the bladder. You would think the ureters would attach to the upper portion of the bladder, and urine would drain in and fill from the bottom up. Urine enters at the bottom. So as the bladder fills, okay, it's going to cover the opening of the ureter. Remember, we said urine is moved through the ureters via peristalsis. And we said that the openings here are little slits. They're not round openings. And covering that opening is a flap of tissue. So what happens as urine is pushed down via peristalsis, and it's under a little bit of pressure, as it hits the opening, that driving force, that pressure pushes that flap of tissue up, allowing the urine to enter into the bladder. As peristalsis ends, that flap of tissue comes down, covering that slit, preventing backflow. Sometimes people have a deformity or something happens with that flap of tissue. And when things like this happens, yes, backflow can happen. Urine can flow backwards up the ureter. And that's only in extreme cases, but it is a potential problem with the bladder. Down here, where the ureter leaves, you will find the internal urethral sphincter. This is a band of smooth muscle fibers that provide involuntary control of urine discharge. So again, this will stay contracted until a certain amount of urine is in the bladder. Looking at the histology of the bladder, it contains a mucosa layer, a submucosa layer, and a muscularis layer. The muscularis layer forms a very powerful muscle known as the detrusor muscle. Contraction of this muscle will compress the urinary bladder and help with the expulsion of urine. From here, urine goes into the urethra. The urethra extends from the neck of the urinary bladder all the way to the exterior of the body. The external urethral sphincter is another band of muscle. This is found in both sexes, but the location or where the sphincter is differs between male and female, and we'll see this in our next unit. This is a circular band, though, of skeletal muscle, so this one is under voluntary control. The external urethral sphincter acts as a valve. Voluntary relaxation of the external sphincter is what will allow or permit the process of maturation. Looking at the histology of the urethra, its lamina propria is very thick and elastic. It's lined with a mucous membrane that has numerous longitudinal folds. Now, this is a true mucous membrane because there are mucin-secreting cells that lie in pockets within the epithelial lining. So the lining of the urethra is kept moist because urine doesn't flow through it all the time. So it helps to keep it moist, and this also helps with the flow of urine. Finally, looking at the process of maturation. This is a reflex. This reflex begins when stretch receptors stimulate the parasympathetic motor neurons. There are stretch receptors in the bladder, so as the bladder fills with urine, this will stimulate those stretch receptors and trigger the reflex. Usually a volume around 500 milliliters or more will trigger this reflex. Once this reflex begins, then voluntary relaxation of the external urethral sphincter will cause the internal urethral sphincter to relax, and this will allow you to void the urine.